Dear colleague, my name is Stephane Gaudry. I work in Avicenne Hospital in Bobigny in Paris area, and I would like to thank the scientific committee for the invitation for this talk on modalities of renal replacement therapy in the ICU. I have no conflict of interest regarding AKI or renal replacement therapy. So in ICU, for our critically ill patients, we have the choice between different modalities: intermittent renal replacement therapy, continuous renal replacement therapy, hybrid machines, and sometimes peritoneal dialysis. We know that intermittent hemodialysis has some advantage. It's widely available. It allows rapid correction of metabolic abnormality, and there is no anticoagulation. However, it might be associated with hemodynamic instability, but sometimes it could be you could have some strategy to improve this kind of issues. What are these strategies to improve hemodynamic tolerance of intermittent renal replacement therapy? You have different intervention: the isovolemic initiation, the reduction in dialysate temperature, the reduction in dialysate flow rate, for example, and something very important is the conservative approach with ultrafiltration. For continuous renal replacement therapy, it might be associated with more hemodynamic tolerability, with low risk of increased intracranial pressure. However, if you use continuous RRT, you should use anticoagulation, and it increases labor intensive and cost in your ICU. The sustained low efficiency dialysis, the SLED, is a modality, a kind of modality. It's an hybrid modality, but the principle is the same. This is the application of conventional hemodialysis technology over a more prolonged period than conventional hemodialysis to render therapy more hemodynamically tolerable. This is an hybrid between intermittent and continuous RRT. So I will focus my talk on the two most used modality, the intermittent and the continuous RRT, and we will discuss the comparison according to mortality, hemodynamic issues, and renal function recovery. What about mortality? This very important randomized control trial was published 15 years ago. This is the HEMODIAF trial, and in this trial, they use a primary endpoint of 60-day mortality, and they compare continuous and intermittent renal replacement therapy. And the result of this trial is that there is no significant difference between intermittent and continuous when you look at mortality outcome after 60 days. And this trial was included in a meta-analysis from the Cochrane collaboration. And in this meta-analysis, we confirmed that the mortality did not differ between the two modalities, which are continuous or intermittent renal replacement therapy. In the same meta-analysis, we had some information about hypotension during the session. And as you can see, here again, no difference between the two modalities. So what do the current guidelines recommend? The KDIGO guidelines, published in 2012, suggest using continuous renal replacement therapy rather than intermittent for hemodynamically unstable patients. However, French guidelines says that continuous or intermittent RRT techniques can be used equally, taking into account their availability and the experience of the ICU team. However, beyond mortality, we now know that long-term outcomes are very important for our patient in ICU. The quality of life is very important, but in the field of acute kidney injury, the renal outcomes, the long-term renal outcomes are very important. For example, dialysis dependency and occurrence of chronic kidney disease. This is important since we know that acute kidney injury is associated with occurrence of chronic kidney disease during the years after ICU stay. So maybe it could be interesting to ask the question of the modality and the renal function recovery in our ICU. One of the first study on this question was published 7 years ago. It is a nice study from Antoine Schneider, published in Intensive Care Medicine. It was a systematic review from 2000 to 2012, including survivors after acute kidney injury. And this systematic review includes 23 studies and almost 4,000 patients. But as you can see, only 12% from randomized control trial. The primary outcome was the dialysis dependency at the end of the follow-up in the study. 43% of patients receive intermittent ART and 57% continue ART. This result is very important to understand the question, because you can see that for the observational study, there is an association between a favorable outcome. So continued renal replacement therapy is associated with more favorable outcome at the end of the follow-up. However, when you look at the randomized control trial, there is no difference between continued and intermittent renal replacement therapy. And another point in this study is that in the observational study, you have this study from Kartin Keba with a very high weight, 10%. And in this study, at the end of the follow-up, the dialysis dependency for intermittent renal replacement therapy patient is 46%. In my opinion, this does not reflect the real life. However, in the conclusion of this paper, the author say that patients who receive intermittent ART as an initial modality for AKI had a 1.7 times increased risk of remaining dialysis dependent. This is a very important result, and that explained this slide from the ECKM 5 years ago. I was a very young PhD, and I was in the ECKM, and Rinaldo Bellomo, an expert in the field, say that intermittent hemodialysis is a nephrotoxic agent, such as starch, aminoglycoside, or amphotericin. And there should be no place for intermittent hemodialysis in ICU. After 5 years, I'm not sure with this conclusion, because this study has a major weakness to answer the question. Indeed, patients receiving continued renal replacement therapy had higher mortality in the ICU. And dead patients cannot be ART dependent. So this is a problem when you look only at the observational study. So we need a composite outcome, death and renal replacement therapy dependency. This composite outcome was used in this very nice French study. This is a prospective observational multi-center study, and the primary outcome was 30-day mortality and dialysis dependency. This study included 1,360 patients, 40% with continued renal replacement therapy and 60% with intermittent. So you can see that the mortality, the 30-day mortality, was higher for patients who receive continued renal replacement therapy, but the ART dependency was higher in the intermittent renal replacement therapy group. So this is the reason why we should use composite outcome. And the result for this composite outcome is that there is no significant difference between the two modalities. However, CRRT associated with decreased mortality and dialysis dependency in a subgroup of patients with weight gain between ICU admission and inclusion. So maybe the hypothesis is that CRRT is better to control fluid balance. This is an hypothesis. Finally, this study was confirmed by other studies. This retrospective study, for example, with data on renal function recovery after 90 days and after 1 year, including more than 600 patients. And in a multivariate analysis, the 90 days ART dependency and 1 year ART dependency did not differ between the two modalities. In this second retrospective study, same result using a French hospital discharge database, including more than 25,000 patients. You can see that the cumulative incidence of survival and renal recovery did not differ. So to summarize, intermittent versus continue RRT. Previous study provide conflicting results. A majority of them are observational study. We have the persistence of confounding by indication. So no modality of RRT shows clear superiority according to when you look at survival or renal recovery. This is the same. And we did additional study to focus on renal function recovery because I think this is a very important outcome. The KDIGO guidelines in a recommendation state that the effect of this different modality on long term, for example, the need for chronic dialysis should be evaluated in prospective randomized control trial. What are the questions for future randomized control trial? Which population? Severe AKI with multi-organ failure, fluid overload. It could be interesting to discuss this population. What kind of intervention? Continue, intermittent, or SLED maybe? And what kind of outcome? I think ART dependency and CKD, chronic kidney disease occurrence, may be good outcome in future randomized control trial. Thank you very much for your